Good morning, everyone. My name is Dr. Maha Guimei, and I'm going to follow up on the lectures of the liver nodules and liver tumors, basically liver masses. As always, you have the objectives of the lecture at the beginning. So we're going to be talking basically this today about hepatocellular carcinoma. In the previous lecture, I've given you an introduction about the liver, the different terminology that we use when we describe liver lesions. We talked a little bit about the liver functions, about the liver histology, and about the benign, the non-neoplastic lesions like focal nodular hyperplasia, and the benign tumors like hepatocellular adenoma or hemangioma of the liver. So this is what we discussed in the previous lecture. In this lecture, we should be starting the malignant tumors of the liver, which is the hepatocellular carcinoma. But in order to do that, we have to go over a certain disease that is a very important predisposing factor for the hepatocellular carcinoma, which is cirrhosis. So I'm going to be talking about hepatocellular carcinoma for a couple of minutes and then discussing this very important disease that is liver cirrhosis. Just to remind you of what we discussed last time, we discussed liver masses or liver nodules, and we said that any mass can be neoplastic or can be non-neoplastic. So as you can see here, we say non-neoplastic lesions. We discussed the focal nodular hyperplasia, and we listed the regenerative nodules, and we're going to be talking a little bit about these ones today, about other inflammatory masses like abscesses, amoebic abscess, pyemic abscess, or in fact other infectious processes like the hydatid cyst. So all of these are differential diagnoses of hepatic masses. And this is very important when you think of a hepatic mass, that you should have all of these differential diagnoses in your head in order to start excluding one after one until you reach your differential diagnosis. And your main purpose when you're doing that is you want to exclude that this is a malignancy. So you want to see if this is a malignancy or if it's not a malignancy, because the prognosis is, as you know, is very much different. So we talked about the non-neoplastic lesions last time, and we talked about a little bit of the neoplastic lesions, which are the benign ones, like the cavernous hemangioma and the hepatocellular adenoma. Today we're going to step a little, one step further and talk about the malignant tumors of the liver. Basically, only in this lecture, I'm going to be discussing a little bit about hepatocellular carcinoma, and then, as I said, I'm going to leave it a little bit and discuss a very important predisposing disease to hepatocellular carcinoma, which is the liver cirrhosis. So for hepatocellular carcinoma, as regards its incidence worldwide, it ranks the 6th among the most common types of cancers worldwide. However, in Egypt, it ranks the 4th among the most common types, and this is due to the high prevalence of hepatitis C virus infection in Egypt. Most hepatocellular carcinomas occur, as we know, all in Asia because of also the prevalence of the hepatitis B virus in these parts of the world, in China, Korea, Taiwan, the prevalence of the hepatitis B virus. However, in the recent years, we have seen a significant decline in the incidence of the hepatocellular carcinoma in these countries as a result of the compulsory vaccination against hepatitis B that has been happening in the past decade. So as I've talked in the past minute, one of the very important predisposing factors for hepatocellular carcinoma is hepatitis viruses, hepatotropic virus infections with hepatitis B and hepatitis C. The age incidence for this tumor is around the age of 40 to 50 years of age. So again, the etiology, the predisposing factors for hepatocellular carcinoma, you can see in red color the most important and the most common ones. So the hepatitis B and C are very important causes for the development of the hepatocellular carcinoma. The next one on the list is a consequence of the infection with these viruses, which is the liver cirrhosis. Liver cirrhosis, again, I'm going to be repeating some words in Arabic, but it's just going to be a repetition of what I'm saying in English, nothing extra. So the liver cirrhosis, وهو تليف الكبد. is a consequence, is one of the complications and the late consequences of the infection with hepatitis B and C. Okay, so most people with hepatitis B and C develop chronic infection, chronic hepatitis, and then from that they progress to liver cirrhosis, which I'm going to discuss a little bit here because you need to know about it in order to understand how a big chunk of these people are at a very high risk of developing hepatocellular carcinoma. The third etiological factor is the aflatoxin, and in addition, which is the aflatoxin is a toxin that is secreted by certain fungi that occur, and this occurs in badly stored grains, nuts. When they are badly stored, there's a lot of humidity. This fungus, this Aspergillus flavus fungus, grows and it secretes this aflatoxin B, and it predisposes to hepatocellular carcinoma as well. Other diseases that may predispose to hepatocellular carcinoma: hemochromatosis, alpha-1 antitrypsin deficiency, the use of anabolic steroids, and others. But as you can see, the major contributing factor, as you look at the diagram, the major contributing factors to this, to the development of hepatocellular carcinoma is the cirrhosis that could be happening on top of hepatitis C, hepatitis B. Cirrhosis also happens in alcoholic patients. So the alcohol leads to the development of liver cirrhosis, and in this disease that is called non-alcoholic fatty liver disease, NAFLD, is again another disease that leads to the development of cirrhosis. And we're going to talk a little bit about cirrhosis in order to understand how, because this is the major contributor to the development of hepatocellular carcinoma. أهم سبب للهepatocellular carcinoma is liver cirrhosis بكل أسبابه, with all its causes, whether it's hepatitis, it's post-hepatitis, hepatitis B and C, alcohol, or non-alcoholic fatty liver disease, as well as others as well. A little bit about, we talked about epidemiology of, I just went backwards. So for hepatocellular carcinoma, as you can see, most of the hepatocellular carcinomas occur in cirrhotic patients. However, only 15 to 20% occur in non-cirrhotic, which are patients who have hepatitis B, C, non-alcoholic fatty liver disease, but are not cirrhotic. However, 80% of hepatocellular carcinomas occur in patients who actually have cirrhosis. Then we need to understand what is the cirrhosis and how does it happen and what are the causes. And it is believed that cirrhosis develops on top of an inflammation in the liver, on top of a liver that is diseased, and it has a lot of chronic inflammation. So the occurrence of chronic inflammation of the liver with death of the hepatocytes, and as we said in the previous lecture, hepatocytes are stable cells. So when there is inflammation, when there is injury, they regenerate. So we have a lot of regeneration of the hepatocytes, new hepatocytes forming. So you have a lot of hepatocytes dying, a lot of hepatocytes forming because of the injury of the old ones. And in this medium, this is a very good medium where autonomous growth can happen, where a neoplasm can happen. A lot of new cells are being formed, a lot of proliferation and division of the hepatocytes. Therefore, this is a very good medium where a malignancy can happen. There are some genes, although we don't really use them in the clinical context, there are some genes, some set of driver mutations that can that happen as a result of this medium where the hepatocytes die and regenerate and die and regenerate. There is a lot of mutations that happen in this medium, like the beta-catenin, the telomerase, transcriptase, and the p53. We don't really use them in the clinical context, however, we know that they exist. So as I said, I'm going to be leaving the hepatocellular carcinoma aside for now. I'm going to postpone it till the next lecture, and I'm going to take the remaining part of that lecture to discuss the very important disease, which is liver cirrhosis, وهو تليف الكبد. Liver cirrhosis, as we discussed in the previous lecture, and as I've shown you in the previous lecture, when we look at the liver from outside, it has a very smooth outer surface. هو الsurface بتاعه من برا ملس, was very, very smooth. In liver cirrhosis, there is complete transformation of this smooth liver surface into a nodular liver surface. And I'm saying here nodular, with formation of nodules, and I'm not using the word lobules. Remember when we talked about the normal histology of the liver, we said lobules, the normal liver lobules. These are not lobules, these are called liver nodules. The disease that is called liver cirrhosis is a common feature in a number of chronic liver diseases. So whatever liver disease happens and remains for a long time, it will end up by developing cirrhosis. It's the end result of most chronic liver diseases. So most chronic liver diseases like chronic hepatitis B, chronic steatohepatitis, alcoholic steatohepatitis, non-alcoholic steatohepatitis, all of these end in chronic liver disease. And most chronic liver disease progress to liver cirrhosis. Of course, this process takes years to happen. It doesn't happen in 1 month, 2 months. It takes years for this chronic inflammation to keep going on and to end in liver cirrhosis. Of course, not all chronic liver diseases terminate in cirrhosis. And when the liver is cirrhotic, it doesn't mean that the function of the liver is lost. We remember in the previous lecture, we talked about the functions of the liver. There are numerous functions of the liver, and the liver has 70 to 80% of reserve. So this means that we need to lose 70 to 80% of the liver cells in order for the manifestations of the liver failure to show on the patient. So liver cirrhosis does not equal liver failure. The patient can have a cirrhotic liver and can be totally asymptomatic. Okay, so it takes years for the destruction of the liver cells to happen and for the manifestations of the liver failure to occur. Again, going back to cirrhosis, it's the change of the normal smooth surface and the smooth architecture of the liver into a liver that is nodular, that is filled with nodules. And what are these nodules? These are the new hepatocytes that form. So you have a lot of hepatocytes that were injured, that were inflamed and injured, and have undergone a lot death of the cells, and new cells that form. So we call these new cells regenerating hepatocytes. They regenerate because of the injury, because of the inflammation. They regenerate and they form these nodules in the liver. So if you look at the histology of the normal liver, so you can see in the middle here, this is the central vein. This is the normal, I'm just going to revise normal histology. Central vein in the middle, and then it looks like the sun with rays around it, like as if this central vein is the sun, and the hepatocytes are the rays of the sun around it. So you see radiating hepatocytes around the central vein, and these hepatocytes are arranged in rows, sufuf, that are 1 or 2 cell thick maximum, yani 2 cell thick, 2 cells or 1 cell, and making a row. Okay, so you can see the rows of hepatocytes, and around the hepatocytes, this pink, these dark pink are the hepatocytes, the rows of the hepatocytes around the central vein. If you look at the cirrhotic liver, this normal architecture is totally lost. So there is total distortion of the normal architecture of the liver, and it is replaced by a new architecture, and this new architecture is formed of what we see here, nodules. I'm not saying lobules again, I'm saying nodules of hepatocytes, nodules, 1, 2, and then the third one here and the fourth one here. These are nodules of hepatocytes, and these nodules of hepatocytes these are regenerating. So nodules of regenerating hepatocytes, and the surrounding blue color here is the fibrosis around these nodules. So this is inflammation. Healing will occur by fibrosis, by fibrous tissue. Normally the liver lobule does not have any fibrosis or fibrous tissue except in the portal tract, this bundle of vessels at the corner of the lobule, if you remember the histology from last lecture. Okay, but in the nodule you have a lot of fibrosis, you have a lot of collagen deposition around these regenerating nodules. Again, I'm repeating, these are nodules. In this medium where we have a lot of dying hepatocytes and regenerating hepatocytes with fibrosis happening around, this is a very good medium where hepatocellular carcinoma can happen. So these cirrhotic patients are at a very high risk of developing hepatocellular carcinoma. So if you look at the if I want to describe the histology, and this is for the purpose of the practical sessions as well, for the practical exam for the OSPE, there is portal to portal fibrosis, bridging all of this fibrosis from one portal tract to the other, from one central vein to the other, forming leading to replacing the normal hexagonal architecture of the liver by another architecture that we call regenerating nodules surrounded by fibrosis. So these are regenerating nodules surrounded by fibrosis. And I'm going to repeat that again. Again, liver cirrhosis. We said that liver cirrhosis is a very important predisposing factor for hepatocellular carcinoma type. What causes liver cirrhosis? What are the causes? What are the diseases that ultimately end up in cirrhosis, and therefore these patients carry the risk of hepatocellular carcinoma? As we talked previously, the number 3 here is the post-necrotic or the post-hepatic, post-hepatitis. So patients who develop viral hepatitis, hepatitis B and hepatitis C, because these are the ones who can progress to chronicity. They can become chronic hepatitis B or chronic hepatitis C. Of course, the risk for chronicity is much higher with the hepatitis C. 80% of patients with hepatitis C develop chronic hepatitis and progress from there to cirrhosis and to hepatocellular carcinoma. And this is a very common scenario, unfortunately, that we see in these patients, and as well as hepatitis B. So this is called post-necrotic or post-hepatic cirrhosis. The other 2 important causes, I've put the very important ones in red, and then the other ones are less common ones, are the alcoholic fatty liver disease or the non-alcoholic fatty liver disease. The alcoholic fatty liver disease occurs in, as the name says, in alcoholic patients. So patients who consume large amounts of alcohol. This results in some forms, if you remember, cell injury from year 1. We said that there is some form of reversible cell injury that is called fatty change. The fatty change occurs in the liver cells as a result of alcohol consumption. So the cells, they become large, they become filled with fat cells, with fat content, and they become large. Okay? So this is called fatty change or steatosis. If the person does not abstain from consumption of alcohol, so with more consumption of alcohol, it's not only fatty change, it's not only this reversible change, it undergoes more disease, which is more inflammation, and we call this steatohepatitis. It's hepatitis occurring in a steatotic liver. So first, if you look at this diagram, the normal liver with consumption of alcohol, it undergoes fatty change. With more consumption of alcohol, it goes to the other side and it becomes steatohepatitis. With more consumption of alcohol, you go to the down one and you undergoes complete irreversible liver cirrhosis, which is the regenerating nodules and the fibrosis. It's the same. Cirrhosis is the same in all diseases. It looks the same, but the causes are different. It always looks the same, but the causes are different. So again, the second cause is alcoholism. The same changes that happen with alcoholism happen with another disease called NASH, non-alcoholic steatohepatitis or non-alcoholic fatty liver disease. The same changes exactly that happen with alcoholic liver disease, steatosis, steatohepatitis, and then cirrhosis. All of this happens exactly with NASH, which is a disease that predominantly happens in obese patients and patients with metabolic syndromes. Patients do not consume alcohol. They do not consume alcohol, but because of the metabolic syndrome and because of the obesity, there is fat deposition in the liver cells. So there is fatty change, steatohepatitis, then progressing to cirrhosis. So these 3 are the most common causes for liver cirrhosis. As I said, liver cirrhosis looks the same in all patients, but the causes are different. Less common causes are metabolic diseases like hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, biliary diseases, primary biliary cholangitis, secondary biliary cholangitis, and autoimmune hepatitis. So the other are also causes for cirrhosis. These are pictures just to show you the difference between a normal liver and a cirrhotic liver. Again, to emphasize that our normal, smooth liver architecture is totally lost. So if you look at A here, this is a picture of a normal liver. And there was a saying that if you just close your eyes and put your hands on the liver, you can easily tell where this is a normal liver or is this a cirrhotic liver, because you can feel the surface. When you feel the surface and it's smooth, then that's a normal liver. If you feel the surface and it is bumpy, then this is a cirrhotic liver. And as you can see here, so the normal liver has a smooth external surface, whereas the cirrhotic liver is studded with multiple variable sized nodules on the surface. If you do the MRI, you can easily see the nodular surface. As you can see, the arrows, the red arrows are pointing at the nodular external surface of the liver. So this is the surface of the cirrhotic liver. So that's the morphology on the gross level. On the microscopy, as we said, you can see the picture here with more nodules. A closer look on how these nodules look like. They can be macro nodules greater than 3 millimeters or micro nodules less than 3 millimeters. It doesn't matter. There are still nodules, and the same. If you look at the microscopy on the right side of the slide, you can see multiple nodules. I'm encircling one of them. This is called a liver cell nodule, and it is surrounded by fibroses. So this is how we describe liver cirrhosis: multiple regenerating nodules surrounded by fibrosis. These are the two important features of liver cirrhosis. One, multiple regenerating nodules. These are regenerating hepatocytes surrounded by fibrosis, and there is total loss of the normal, beautiful architecture of the liver. Another picture just to show you that histology again. These are liver nodules of the liver. You can see them here, nodules. All of these rounded pink structures are the regenerating nodules, and they are surrounded by this blue color. We stain these slides with a stain called trichrome stain, Masson trichrome stain. You can find it here, Masson trichrome stain, that gives the fibrosis a blue color. So you can see this blue color surrounding all these nodules. Again, regenerating nodules surrounded by fibrosis that is stained here in blue. Okay. Now we know that what cirrhosis looks like. We know the causes of cirrhosis: the post-hepatic, the alcohol, the non-alcoholic steatohepatitis, all the other causes of liver cirrhosis. We know how cirrhosis looks like: the bumpy, the nodular liver, and on histology, the nodules and the fibrosis. Now we go to the pathogenesis of cirrhosis. Why does it happen? How does it happen? The pathogenesis of liver cirrhosis. So in order to understand the pathogenesis, I want you to look at the diagram on the left side first. I'm sorry. I want you to look at the diagram on the left side, and you can see the hepatocytes here on the down here. You can see these are hepatocytes, and in between the hepatocytes we have the bile canaliculi, because we know the function of the liver cells, the function of the hepatocytes is to synthesize the bile, and then they secrete the bile into these canaliculi. These hepatocytes, they swim in blood, they are soaked in blood. So they are immediately in touch with the blood sinusoids. This is sinusoids, these blue here is filled with blood. Only separating them from the blood is a layer of endothelial cells. These are endothelial cells that are fenestrated, that have pores, because the liver cells have a lot of function that has to do with secreting substances in the blood and taking up substances from the blood to detoxify. So they have to swim, they have to be soaked in blood. So, and if you have seen a liver you got from the butcher, you can see how bloody the liver. Now you're never going to eat liver again, I'm sure, like I do. You're going to find the liver is very bloody. This is because all the hepatocytes, they are actually soaked in blood. And that's what you see here. These are the hepatocytes, and that's the blood in direct contact with the liver cells, only separated by this thin layer of endothelial cells. There is a tiny space between the hepatocytes and the endothelial cells that we don't even see by light microscopy. You need an electron microscopy to see that space. This is called the space of this. So again, these are the hepatocytes here, down here. These are the endothelial cells separating the hepatocytes from the blood sinusoids. And the space in between the endothelial cells and the hepatocytes is called the space of this. Okay? In the space of this here, there is one cell called a stellate cell. It's a quiescent, inactive stellate cell. It's just a storage cell for vitamin A. It's a cell that stores vitamin A only. There is nothing else in this cell. But this is under normal conditions. When the liver is inflamed, when there are inflammatory conditions in the liver, this cell becomes activated. The stellate cell becomes activated stellate cell, and it turns into a myofibroblast. And this myofibroblast starts laying down, as you can see here, collagen, dense extracellular matrix, and then the end result, you have a lot of fibrosis, you have a lot of collagen and fibrosis in here, in this space between the hepatocytes and the endothelial cells, and subsequently between the hepatocytes and the blood. So the hepatocytes are no longer soaked in blood. There is a layer of fibrosis that separates them from the blood. And when they are soaked in blood, they get their nutrient, they get their oxygen from the blood, and now they don't have the nutrients, they don't have the oxygen, they cannot perform their functions because of this layer of collagen separating them from the blood. Okay. The other thing that happened is this fenestra, because of the fibrosis that is happening, these fenestrations, they close. There is loss of the fenestrations between the endothelial cells. So the end result of all that process, you have a lot of fibrosis here in the liver. Normally the liver does not have fibrosis, as I said, except in the fibrous tissue, except in the portal tract. So we don't have fibrosis around the hepatocytes. Now we have a lot of fibrous tissue around the hepatocytes. Now the hepatocytes are no longer able to do their work because they're separated from the blood. So the liver function is going to be compromised. So the end result of all of that is the death of the hepatocytes. So because they can no longer get their nutrients and their oxygen from the blood, so there is death of the hepatocytes. And with death of the hepatocytes, you have a lot of regenerating nodules, regenerating hepatocytes growing, because as we said, these are stable cells. When injury happens, only when injury happens, the cells start to regenerate again. The other end result here is a lot of extracellular matrix deposition, a lot of fibrosis being deposited, and there is vascular reorganization. So where are the hepatocytes are going to get their blood supply? The new vessels need to form. The vascular organization of the liver, the vascular makeup of the liver is reformed. So these are the end result of all that process that we talked about of the inflammatory changes, the quiescent cell, the stellate cell. This stellate cell, we also call it eto cells. They change into myofibroblast. They start laying down collagen in the space of this, and the end result of this, a lot of collagen being deposited in the space of this, that the hepatocytes will die, a lot of extracellular matrix deposition, and the vascular reorganization. Does this mean that cirrhotic patients will symptomatize, will develop symptoms of liver failure? No, as we said previously, the liver has a lot of reserve. 80% of the liver cells must be lost in order for the patient to start symptomatizing. At late stages of liver cirrhosis, they may start having some clinical manifestations like anorexia, weight loss, weakness, and eventually signs of liver failure. Now we know what is cirrhosis. Now we know the causes of cirrhosis. Now we talked about the pathogenesis of cirrhosis. But most importantly is the complications of liver cirrhosis. This is why in the first place we started talking about cirrhosis in this lecture, because we need to know why is it a risk factor for hepatocellular carcinoma. But is hepatocellular carcinoma the only complication of liver cirrhosis? No. We have 3 important complications of liver cirrhosis. One is portal hypertension. I'm going to talk a little bit about that in details. Two is hepatic failure, and we'll rediscuss the functions of the liver and the symptoms of hepatic failure. And three is the risk for hepatocellular carcinoma. So number one is portal hypertension. As you have seen from the previous pathogenesis slide, that there is vascular reorganization. There's a lot of fibrosis happening in the liver, and this fibrosis is compressing the vasculature, the vessels and the sinusoids. So this will ultimately lead to the blood pressure in this portal circulation going up, and this is what we call portal hypertension. The blood pressure in the portal vein increases as a result of the fibrosis happening, the vascular reorganization happening. The portal hypertension will develop, as you can see. When portal hypertension develops, we have a lot of complications for that, a lot of consequences for that. The four major consequences for portal hypertension are: one is hepatic encephalopathy. Hepatic encephalopathy, and I'm going to discuss all of that in a bit. Two is ascites. Three is congestive splenomegaly, and four is formation of portal systemic shunts. So again, portal hypertension is one of the very important consequences or complications of liver cirrhosis. It is the increase in the portal venous pressure. The etiologies include number one, cirrhosis, as well as other like vascular obstructions and schistosomiasis. And there are four major consequences for this portal hypertension. Now I'm going to discuss these four major consequences of portal hypertension. Now, when the blood pressure in the portal vein increases, there is ascites that will happen. Ascites is the collection of fluid in the peritoneal cavity, and as you can see, there is this tension of the abdomen with fluid collection in the peritoneal cavity. And this fluid is a transudate. It's not an exudate, it's a transudate. There is portal hypertension, there is an increase in the hydrostatic pressure in the portal circulation, which leads to oozing of the fluid and the plasma outside, transudate accumulation in the peritoneal cavity, and this is what we call ascites. Okay. The second consequence of portal hypertension is the enlargement of the spleen, because the portal vein is the end result of the joining of the splenic vein with the superior mesenteric vein to form the portal vein. So if there is an increase in the portal pressure, this increase in the pressure reflects in the splenic vein, in the engorgement and the enlargement of the splenic vein, and consequently by enlargement of the spleen. So we call this congestive splenomegaly. The huge enlargement of the spleen, we call it congestive splenomegaly, which ultimately will result in what we call hypersplenism. Like the spleen will start sequestering and eating up the blood cells, like the red blood cells, the platelets, which will ultimately lead to anemias and thrombocytopenias in these patients. The most important consequence of portal hypertension, as we said, consequences of portal hypertension are: one, ascites; two, splenomegaly; and three is the opening of the portosystemic shunts. What does this mean, the opening of the portosystemic shunts? If you look at this diagram here, you can see the liver that is cirrhotic and nodular. You can see the portal vein that is hugely dilated and engorged with blood, because there is resistance to the flow of the portal blood into the liver because of the fibrosis and the regenerating nodules. So the vein is engorged with blood. So what will happen here? There's back pressure of all that blood in this portal vein back to its tributaries. And the tributaries, as we know, to the splenic vein. So this results in enlargement of the congestive splenomegaly. And again, into the left, this is called the left gastric vein. This left gastric vein drains the lesser curvature of the stomach and drains the lower esophagus, the lower part of the esophagus. So when there is an engorgement of the blood in the portal vein, you have engorgement of the left gastric vein, you have engorgement in the lower esophageal veins. And this leads to opening of those shunts, of those small vessels in between the portal circulation and the veins of the systemic circulation, which are the tributaries of the azygous veins in the lower part of the esophagus. This leads to connections and shunts between the portal blood that is coming back from the liver and the systemic blood that is draining from the azygos vein into the inferior vena cava. The opening of these veins in the lower part of the esophagus results in what we call esophageal varices. A varus is a dilated vein. So esophageal varices are dilated veins, submucosal veins in the lower end of the esophagus. So is this important? Yes, it is very important, because these veins may easily rupture. They can easily, with ingestion of food, these veins are dilated, engorged, the pressure is very high in these veins in the lower esophagus, and that's an area where food is passing. So with injury to the mucosa and with high pressure in these veins, they can easily rupture, resulting in vomiting of that blood. And the vomiting of the blood is called hematemesis. Okay? And these patients are at risk of dying. There's a 50% chance of dying in a first attack of hematemesis. So this is a very important cause of death in these patients, is the rupture of these esophageal varices, and the patient coming with severe amount of hematemesis and loss of lot of blood from the esophageal varices. So that's the most important site where portosystemic shunts happen. The opening of these shunts between the portal circulation and the systemic circulation results in those large veins, large dilated engorged veins in the lower end of the esophagus. These veins are at risk of rupturing, and the patient presenting with vomiting of blood that we call hematemesis. Hematemesis وهو vomiting of blood. The patient, as I said, is at a 50% chance of dying in the first attack of hematemesis. However, we treat these attacks with sclerotherapy, with different methods of treatment, and the patient can have recurrent attacks of hematemesis. The other site where the systemic shunts open is around the umbilicus. The pictures here, the picture number C, shows you the endoscopy picture of all those dilated and engorged veins in the esophagus. This is an endoscope going into the lower end of the esophagus, and you can see those dilated veins at the lower end. These are the dilated submucosal veins in the lower end of the esophagus, and these are the veins that rupture. These are the esophageal varices, and they can rupture and result in hematemesis. The other site, as we said, is around the umbilicus. This is again a site where veins from the portal circulation communicate with veins from the systemic circulation, and they become also dilated, and they form like the hairs of the witch. They call it caput medosa. The hair of a witch. As you can see, the dilated veins radiating from the umbilicus, we call that caput medosa. The third site where we have a portosystemic shunts happening, or opening of portosystemic shunts, is in the lower rectum and the formation of piles. Again, why are we discussing all of that? We discussed liver cirrhosis, and from liver cirrhosis we jumped to portal hypertension with the consequences of portal hypertension. Another consequence for liver cirrhosis is liver failure. So we said there are three main complications for portal hypertension, for liver cirrhosis. One is portal hypertension, and we discussed it with all its complications. Two is the risk for hepatocellular carcinoma, which is why in the first place we are discussing that. And three is hepatic failure. What are the manifestations of the hepatic failure? Number one is patient complains with the jaundice and pruritus, because liver is an important cell that forms the bile. So with dysfunction of the liver cells, there is stasis of the bile, there is cholestasis, stasis of the bile in the liver cells. It goes back to the blood, and this results in jaundice. The liver is a site for detoxification of a lot of hormones, toxins, proteins. So one of that is the estrogen is metabolized in the liver. So with failure of the liver, the estrogen is no longer properly metabolized, and this manifests as pulmonary erythema, redness in the palms, spider angiomatous, these dilated veins on the skin. These are all manifestations of hyperestronemia. And if it's a male, you have hypogonadism and gynecomastia in addition to that. Another manifestations of hepatic failure is hepatic encephalopathy. And encephalopathy means the liver is important in the detoxifying ammonia, or the ammonia that is absorbed from the gut goes to the portal circulation and it is detoxified by the liver. This does not happen when hepatic failure happens. So the ammonia goes to the systemic circulation, crosses the blood-brain barrier, and result in behavioral abnormalities, confusion, stupor, and even coma and death can result from all of this hepatic encephalopathy. Fourth is the coagulopathy. Again, as we know, the liver is a site for synthesis of a lot of the coagulation factor. 2, 7, 9, and 10 of the coagulation factor are synthesized in the liver. So with abnormal liver function, you no longer have proper synthesis of these coagulation factors, which results in easy bleeding, easy bruising, so bleeding diastasis or coagulation problems. This is just a repetition of what we discussed last time of the serum markers used to test for the liver functions. I've explained that in the first lecture, so I don't need to go over it again. I have one question here. It's a 43-year-old male with a history of chronic alcoholism and hepatitis C. So he has alcohol and hepatitis, both two predisposing factors. It is brought to the emergency room by his friends because he has twice vomited large amounts of blood. What do we call the vomiting of blood? We call it hematemesis. Other than the 2 episodes of bleeding, he had not otherwise been vomiting. He had 2 episodes of this vomiting of blood and nothing else. Which of the following is the most likely mechanism for this bleeding? So in order to solve any of these clinical scenario problems, you need to read the scenario and make your diagnosis first before you look at the options. So if you read the scenario and you know this is an alcoholic patient and he has hepatitis C and he presented with hematemesis, how can we link all of that together? He probably has a chronic hepatitis C or chronic alcoholism that led to liver cirrhosis, and with liver cirrhosis there is portal hypertension. Okay, and the consequences of the portal hypertension is the opening of the portal systemic shunts and the esophageal varices happening, and the patient will present with hematemesis. Okay, so this hematemesis results from the rupture of the esophageal varices. So if we look at all the mechanisms here, is it acute alcohol toxicity? Of course it's not. Is it a tear in the esophagus? Of course it's not tears in the esophagus. This is called Mallory-Weiss syndrome, and it happens in alcoholic patients as well, but it's not in hepatitis C. Patients, rupture of a dilated vein. Yes, actually, this is the answer. It's a rupture of the dilated submucosal veins at the lower end of the esophagus, which is what we call the esophageal varices. So the answer here is C. Thank you very much. I've concluded this lecture. I hope this was clear and beneficial.